Good morning, or good afternoon to a few of you. Hopefully not good evening, although my last call there was someone from Australia on there. So he said he was in the future, which I thought was really kind of hilarious. My name is Adamika Arthur. I'm the CEO and Executive Director of Health Tech for Medicaid, and really excited today to be talking about the role of data analytics as it pertains to population health management. I'll just briefly say, many people know I'm an epidemiologist by training and ran hospitals for about 15 years before starting Health Tech for Medicaid. So any sort of data analytics is like my love language, but also in the context of population health management, especially with all that we have going on in our provider, payer, and payvider communities, is such a critical topic. And we're really thrilled to have such a really a wide range of payers and providers from across the country, and also our co-conspire in this webinar, which is Cope Health Solutions. Next slide. Certainly feel free to introduce yourself in the chat. We will be gathering information from the chat. If you've not been on a Health Tech for Medicaid webinar before, we try to make these as interactive as possible, meaning that we try to make sure that any of your thoughts, comments, suggestions are put in. While we'll try to get through, we always try to start on time and end on time and really hold to people's time. I'll tell you briefly about Health Tech for Medicaid and we'll kick off the webinar. So Health Tech for Medicaid is dedicated to supporting innovation in Medicaid. Our purpose is really to improve quality, equity, and access to care for Medicaid recipients and their caregivers, which ultimately make up many of our families around the country and our communities. There's 94.1 million people on Medicaid, plus or minus about 1 million that have been kicked off because of Medicaid redetermination. And I will just preface, I'm saying everywhere across the country right now, and any audience that I speak to, it is Medicaid redetermination. If you do not know what that is, please let us know. We will loop you into the many efforts, but it is essentially as COVID-19 public health emergency has ended, we've decoupled that, and we are now in the what we call Medicaid unwinding, meaning that we are redetermining everyone on Medicaid through the course of the next 16 months now. We have an entire education series and would be willing to help anyone and everyone. We are trying to hopefully get everyone who stays insured, whether they go onto the state exchange systems or return back into Medicaid. What we do not want is more uninsured in this country. At Health Tech for Medicaid, we call ourselves a mission-based market enabler. We're really a convener. We bring together payers, providers, policymakers, entrepreneurs, investors, advocates, and most importantly, we center all of our work on people on Medicaid and their caregivers. So we hope you feel included in that. Next slide. All right, let's talk. We're kicking off today talking about data analytics and population management. I'm just going to give some frame. Obviously, we know that data analytics plays a really crucial role in population management. You actually can't do population management well without, as I consider, disaggregated data and then using that data to figure out what you're going to do with it. And that really helps payers and providers really gather and analyze these large volumes of data that we have. And of course, large volume data has meant something very new and different with the advent of AI and other models coming into the large machine learning models coming into this. But we really want to focus on, our experience over the last 15 years or so with electronic health records. We've had claims data. We have now a lot of people are focusing on SDOH or social determinants of health, although I would say there's also political, economic, environmental, and other determinants of health. And there's also self-reported data. How do we deal with all of this? How do we have the intersections between them? So how do we identify gaps in our systems, better allocate resources, prioritize our interventions, or really actually have a co-created environment where we're working with folks on their health and empowerment. Next slide. I'm just going to give a slice of the payer's perspective. We have Errol on, and I know he's going to go deeply into this, but a lot of our payers really are looking deeply at this approach and kind of figuring out how they're doing predictive analytics, who they're working with to get that done. Oftentimes they need a partner in getting that done, and really to help them inform decisions specific to programs, but also on the both regulatory and policymaking side of health care. Next slide. We also have a slide from the provider perspective, which you're going to hear from both coasts, which I find to be really exciting. And Alan is kind of sitting somewhat in the middle, but they do a lot of work across the country. So we'll be able to give you examples from, I know they've done work in Ohio, many other places in Middle America. But, really all sorts of providers, federally qualified health centers, clinics, hospitals, both public, private, and in between, really all have to utilize data to really look at care coordination, risk allocation. But, more than ever, as we're looking at health equity across the ecosystem, CMS has given a lot of guidance as it pertains to that. So that's kind of setting up why data analytics and population management is important. And I'm going to actually turn it over to Alan. We will be active in the chat, but looking forward to hearing from our panelists in the next 56 minutes. Thanks.
Thank you so very much, Adamika, both for the great overview and for allowing us to be here and for enabling this discussion. So I feel very fortunate. I'm actually sitting in Buffalo today, but our firm is a national company. Cope Health Solutions, just very briefly, so you know who we are and why we're here. We're a national tech-enabled solutions firm focusing on improving the access to and really enabling success in value-based payment arrangements for both payers and providers. So helping payers make providers successful, and of course, payers being in risk themselves, always helping them succeed. And at the same time, helping providers get access to more premium and really succeed in being able to manage that premium well and align the financial incentives. At the same time, we're one of the largest health workforce development, training, placement, pipeline companies in the country. And so we're really excited to get to be here today. And by the way, if you're wondering, COPE actually used to stand for Community Outreach for Prevention and Education. So when it comes to SDOH, our firm was born in the community, actually helping homeless families back in the mid-90s. Unique for a firm like ourselves to have evolved the way we have. We feel very fortunate. So I would like to briefly introduce my colleagues today because they are fantastic people. We have Dr. Efrain Talamantes, who actually, believe it or not, was a student in one of our programs, helping those homeless families years ago. He is the Chief Operating Officer at Altamed. He'll tell you a bit about what Altamed does. They're a fantastic organization operating out of Los Angeles, very deep in risk for many years. We have Mr. Errol Pierre, who is an incredibly talented health plan executive with years of experience, Senior Vice President of State Programs with Medicaid and long-term care at Health First, which is a very large and very important successful plan in New York. Actually, it's provider owned and sponsored by multiple providers. And Errol will tell you more about that. And then we have Jing Shui, who is both health plan and provider, has a wealth of experience in data analytics, very, very deep on both the plan and provider side. Now the Chief Strategy Officer for a very large and successful IPA in New York called Chinese American Coalition of Asian American IPA, pardon me. And so what I'm going to do to kick it off, we'll ask some questions, but I'm just going to ask Dr. Talamantes and then Errol and then Jing, could you each just briefly tell folks a little bit about the organizations you're in and the role you play?
Yeah, certainly, Alan. I can start. Efrain Talamantes, I'm the Chief Operations Officer here at Altamed. We are the nation's largest federally qualified health center. We serve about 400,000 patients in Southern California, both in LA and Orange County. We have grown from a storefront free clinic over the past 50 plus years to a robust health primary care delivery system. But as we've taken on more responsibility, risk of our patients, really developed a specialty network, really partners at hospitals, and really looking at from our lens as an internal medicine physician, how can we be successful in not only thinking about the patient that's in front of us, but also ensuring we're taking care of all those patients that may not be accessing care in a more proactive way. And really, it's an incredibly dynamic organization in that not only do we have a mission to eliminate health disparities, but the social determinants have, again, also been part of our DNA. And really that we're pushing the envelope on not just the clinical services, but the human services that oftentimes our patients present with that impact healthcare. So happy to share more about that and looking forward to the discussion with these distinguished panels. And thank you both, HealthTech for Medicaid and COPE for having me here today.
Errol, go ahead. Sure. Hello, Errol Pierre. I am Senior Vice President of State Programs at Health First. Health First is the largest nonprofit health plan in New York. We serve now 1.9 million members. That's obviously before we've started our Medicaid redeterminations, but our hope is that we stay as close to 1.9 as possible with all of our efforts. We also are roughly averaging around 16 billion in revenue every year across our products, which includes Medicaid, Medicare, where more than 60% are duals, long-term care, and our commercial products, most of which are on exchange members. Lastly, 15 hospitals across New York State sit on our board and take full risk. Those hospitals are the likes of Northwell, Mount Sinai, NYU, all the academic medical centers, as well as safety net hospitals like H&H and other hospitals like Jamaica Hospital. And that's a full risk arrangement we have with them, as well as our community providers, which is really unique to have in New York, as well as just nationally across all of our product suites.
Hi, everyone. My name is Jing Shui. I'm the Chief Strategy Officer at Kaipa, and I also oversee the data analytics function at Kaipa. I've been with Kaipa for 4 years, and prior joining Kaipa, I was on the health plan side and worked for Emblem Health for 20 years. So it's really, I've seen both perspectives from health plan side versus provider side. About Kaipa. Kaipa is a major provider group, primarily serving in the New York City metropolitan area. We have over 1,200 independently practicing providers, serving almost 500,000, patient population. Of those 500,000 patient population, over 300,000 are currently under one of the VBP programs that we have with various different health plans. Health First being one of the biggest partners, and Kaipa and among the provider group here in New York is one of the pioneers in the VBP program, and we've been taking the VBP risk for many years. As a matter of fact, we are one of the 4 entities in New York State designated by the state DOH as Medicaid innovator, which means we can take more advanced VBP models all the way, including full risk total cost of care. So I'm very happy to be here, share my experience with you, and also listening to many inputs and ideas from you as well. Thank you.
Thank you so much, Jing and Errol and Dr. Talamantes. So I'm going to go ahead and just kick it right into our first question. I'm going to start with you, Jing. You really have lived your life, as you said, in data analytics and still do today. So could you help the group understand from your perspective, how can we best use data and what types of data to really improve health and patient outcomes with relation specifically to being in those value-based payment agreements that you all have been in so long, and of course that you manage in the health plan world?
Thank you, Alan. And like I mentioned, Kaipa has been with the VBP program for many years. And during those years, really data analytics played a very important role in our success in the VBP program. And looking at the role of the data analytics, I think mostly on 2 fronts. One is on the clinical management, the other one is on the financial management of the VBP programs. On the clinical front, mostly first and foremost is population health management, population health assessment. We gather claims information from the health plans. We gather our, the lab data from different vendors. We get our own care management, data from our programs. We compile the data together, and we identify among our patient population, those with chronic conditions and those with high clinical risks. And we have, based on the data, we help the clinical team to create various different care management programs. And also on an ongoing basis, our data analytics are run a monthly process to identify, refer those patients into those care management programs. As a matter of fact, those are the high risk, potentially high cost patient. That's, are clinically very important for our success in the VBP management. The other aspect in the clinical front is really quality management, because quality is the key while you're delivering the care. So what we do is we leverage the quality gaps data that we receive from health plans and also incorporate the data into a new app, software app, we call the POC, that sits on top of our provider's EMR system. So every time a patient comes to the office, all the quality gaps will pop up. So we run the analytics to feed the data into this, POC tool. At the same time, we identify, these quality gaps and those low-performing measures, and also those target providers. We help the outreach team to have a regular, intervention process to reach out to the providers to target those measures we have, specific challenges. And also with the data, we have an ongoing monitoring process to monitor our quality performance. So those are the things we use the data in the clinical area. The other front is the financial management. As you know, in a VBP contract, and we're at a financial risk, especially if you're on a two-sided risk. We bear the risk if there's any downside, outcomes. So it's very important to manage the financial aspect. What we use the data, and we use the data, again, claims data, the risk score, the revenue, potential revenue we have, and to monitor our overall utilization and cost, our bottom line performance on an ongoing basis. And we can, with the data, we can identify, if anything, the emerging trends where we can take some preemptive actions. And also we work very closely with our health plan partners like Health First, with ongoing data meeting to review our performance, review our utilization and cost. And the other aspect on the financial side is really use the data to manage our own providers' performance. And we developed a quarterly PCP report card. And we look at the PCP's panel's performance, both from their MLR perspective and from different aspects of the utilization. Compare their panel's performance against the overall CAIPA's network benchmark. So in addition to that, we identify the 10% low-performing providers and to conduct a further drill-down analysis to help these providers to identify the underlying root causes. By the way, for the drill downs, we use additional tools like a COPE's ARC tool. We run the individual providers and even patient level data to help them understand the root cause. So this is the PCP front. And for the specialist, we also run the efficiency performance assessment across several major specialties. And we identify among individual specialties those efficiency providers, and we gave those providers, like an honor roll, and also we share the information with our PCPs to encourage them to refer patients to those efficient providers. That's how we do financially to manage our financial risk, manage our VBP contract. So both the data analytics has been used in clinical front as well as the financial management front. To sum up, CAIPA has been very successful in the VBP program. And if anything, I think one of the secret sources we have is data analytics. So with that, I'll hand it back to Alan.
Thank you so much, Jing. I think that was incredibly valuable for folks. Really, really solid overview. And I love how you talked about financial and clinical, because it feels in healthcare sometimes like people forget how important those financial incentives are, right, to those physicians and others. So I'm just going to ask Errol. Errol, I know you've done a lot of work around this from the payer perspective. Do you have any thoughts to add to what Jing talked about?
Yeah, Jing was very comprehensive, so it's going to be a tough act to follow. What I will add is it's important, and you can hear it in all of Jin's comments, to have a culture of data, a respect for data. And what I mean by that is if you do not invest into tools and teams that are going to spend time looking at the data, you won't get these outputs. And a lot of times, sometimes this is an afterthought, not something that is pushed to the forefront. And we did a lot of work at Health First to make sure that we had infrastructure, data analytics, even data mining, data science, the technology you need so that we have a single member record. So master data management, all for the fact of knowing how powerful our data is. The other thing I think that's important too is I have the luxury of working for a plan that is also very high on the list in value-based payments. Again, 80% of our $16 billion in revenue are in a full upside downside risk arrangement. So what that means is we are only focused on value for our providers, for our members, and for our hospitals. If I was fee for service and say 90% of my payments were fee for service, I don't know I would have an orient towards providing data to providers as much as I do being in a full risk arrangement with so many providers. What I think we're able to do for providers is provide information that's probably their blind spots. So what's a blind spot for a provider? They may see, their specialist may be seeing the patient, but unbeknownst to them, that patient's also seeing another specialist that's not part of their TIN. And so we now can help them to say, there's leakage or your members going outside of your network. And what does that look like? And then that's helpful for providers to then say, oh, let's find out why they need to go elsewhere. Maybe there's a gap from our services, or maybe it's just patient education. And so I think we do a lot of work on the blind spots for providers to provide the best kind of care. The other thing I'll mention too is, and Jin spoke to this, is baselining. So it's one thing to say our PMPM cost for maternity care is $6 PMPM, for example. It's another thing to say this hospital PMPM cost is $8, this hospital is $4. Now, why is that? Maybe it's risk. Maybe they're taking care of sicker children. And so if there's correct risk collection and data accuracy on the risk collection, then we could say, oh, that explains the difference. Maybe it's from not sending enough claims. So if it's a capitated provider, maybe we're not getting all the encounters, so we're not getting the right reflection of the burden of the patient, which is important. And because we have these baselines, we're able to have these types of conversations with the provider, which leads to better performance for them. One thing that KIPA asked for specifically is, I just don't want to see the Health First baseline. Let me know baseline for a similarly situated provider. And that even gets into more focus so that they can tell how they're doing against their peers, similarly situated peers, which is very important, which you can only do with a plan that's wants to work with you in that way with that amount of data. The last thing I'll mention too is we still send out faxes and we still send out Excel spreadsheets. And I'm waiting for the day when we are tapped into a provider's EMR directly. So I don't have to send an Excel grid of gaps of care with, 3,000 names that they take and then put into their system, but I can automatically send it to them. And maybe like APIs where they're pinging against our own system. And I think that's where the evolution of where we need to get to, so that we're not doing batches, because batches are still Flintstone car way of doing healthcare, and we're trying to get to the Jetsons spaceship.
Thank you so much, Errol. Again, between you and Jing, so comprehensive. So Dr. Talamantes, let you follow that. I mean, you obviously, of course, are working for an organization that's also been very, very steeped in risk. You even have one of the largest PACE programs in the country. Can you talk a little bit about, what have you seen as critical success factors in California and in your model, and anything specific to FQs that people should think about versus other types of providers?
Yeah, no, I've been very fortunate to be at Ultimate for the past 5 years. And, I think the first message is don't go into a new EHR. Epic, we went into Epic right before the pandemic. We also launched our Altura MSO, Managed Service Organization. And again, right prior to the pandemic. So it's been incredible to see from the ground up how we've really blown up our systems on the data side and had to come back and rebuild them. And both, I think that what we're seeing is As providers, as shared, there's so much data that's already at the payer level that is being collected by our clinical teams and even our community health workers. We have a very robust number of community health workers, and really thinking about it in several buckets. I think one is thinking about not only the clinical, and I know we've talked a little bit about the financials, but also the social data, the social determinants or drivers of health, and really thinking about how we put all that together. Ultimate, prior to changing our data systems, both was already well on their way on both collecting social determinants data and using that as a way to identify not only risk, but also be more proactive as a provider group in terms of how we reach those patients, both for those that have insurance, Medi-Cal. I think that some folks fall off insurance and come back. And we are very fortunate as a federally qualified community health center to no matter if you're insured or uninsured, we're going to take care of you. And ensuring that both we're looking at quality from that perspective and really not only understanding it from a demographic standpoint, but also understanding it from whether they're insured or uninsured, and are we meeting those quality measures? And now bringing in the social data to really understand again, those patients, identifying those patients that are the most vulnerable to make sure that we're intervening. So that's helped us as a provider group, for example, develop our transitions of care program. So as we're getting data from our managed service organization, we have a very focused transitions of care program where we know the patients that are in the hospital now or on the verge of being discharged. So we're able to communicate directly with those patients proactively, getting them into our primary care setting and making sure we're doing all the work we need as a provider group, not only med reconciliation and so many important things that really could result in a readmission or adverse event. But more importantly, again, using those assessments, the social assessments to know whether we need to activate not just the care manager, but a community health worker, a promotor to come in and really using our community as an asset to help that individual, knowing that we're in some of the most underserved areas in the country here in Los Angeles. And now we're moving to being more proactive about identifying risk for potential ED, emergency department utilization. Again, in developing targeted interventions. We're using a more proactive telehealth approach to make sure that those patients that maybe our clinics are right now, we're seeing way too many more patients than we have providers. We're always in need of more providers. Sometimes our nurses can step in and triage, but we do have a telehealth intervention where people can be seen the same day. Our goal is to see people or access them, whether by video or phone, in an hour, making sure that those patients who don't necessarily need to go to the emergency department, that a physician or an advanced practitioner can come in and intervene before they end up in the ER for things that we can take care of. And then lastly, I would say, part of not only building out these types of interventions, we are now on the verge of moving into an alternative payment methodology here in California. So both that we've been taking increasing risk with our current population. Now we have an opportunity to really move away from fee-for-service completely into a full value-based payment arrangement where we can be a lot more proactive in developing programs that are not dependent on people showing up, but we're actually doing a lot more proactive work to make sure that they're being cared for. the big areas of opportunity for us are obviously how we, again, the integration piece, I know that was shared as well, is thinking about how we start to really integrate with our specialty network and the hospital network. There's a lot of opportunity there where, again, there might be patients, as an internal medicine physician, it's very important to me that I know where my patient's being seen and that I have a say in what is being done, partly because I have the full picture. I can really understand whether that patient, oftentimes I have patients who come back to me and say, the doctor kept referring me to the orthopedic surgeon, but I don't want surgery. And so again, maximizing, we know that specialists are already overburdened with too many patients, making sure that we start looking at that data and developing our value-based arrangements with both specialists and also our hospitals. And again, it's threefold. It's really looking at the clinical, social, and financial data to really guide us. And that's really been exciting, both in that it's a two-way street. I think as a provider group, we tend to be very active. And sometimes it's having that conversation with our own MSO or our health plan. We also have Ultimate Health Network, where we're taking, that's our limited Knox-Keene, restrict Knox-Keene, where we're taking all the risk for those patients. And we have a lot more leverage to have these kinds of discussions around shared data and even thinking about what the current gaps are, but being at the table to have a proactive discussion about where we want to be 5 years from now. And that's been a real opportunity for us, because I think for our provider group, we know we can better weather any storm. I know, when the COVID pandemic hit, many of us, we were fortunate that we're already in risk. So we had something to depend on, but moving into a value-based arrangement gives us a lot more opportunity to weather a lot of uncertainty in Medicaid, whether it's redetermination or other challenges. January 1st, 2024, California is moving to ensure all undocumented individuals in California will qualify for Medi-Cal. And so we really want to, we have a process where we're going to look at all that data as it's coming in, because we know some of these individuals haven't accessed care for many years in their life. And so we're trying to play catch up. And so that's where the payers become a partner in making sure that we take care of those patients, get them on the right track, and avoid some of the adverse outcomes, both clinically and socially, that we see here in California.
Thank you so much. No, thank you, Dr. Talamantes. I think it's a really rich discussion. I hope folks are really getting, I know they're getting value out of it, because it's incredible for me. I'll just share briefly, as you hear Jing and Dr. Talamantes and Errol talk about these things, it's funny, Errol and I teach a class together at Columbia, and we're constantly talking to doctors and others who are in our course about how do you get this data? How do you get the plan to give you the right data? And so food for thought for all of you on the call as you're thinking about this. Some of you are probably thinking, well, first of all, how do I get into a value-based payment arrangement? And second of all, if I get into one, how do I get the data? Because the plan doesn't want to give me the data. And so what we always tell both our clients, but also Errol and my students, is the good news is you get what you negotiate. Plans can struggle with data just like everyone else, but you should be really thoughtful as you're hearing this conversation, right? Because you do need claims data, right? You do need eligibility files that are clean. You do need financial settlement reports. Those are very important things to have. And I'm going to have the speakers walk through in a minute some of the key data points. Just want to remind you all that as you think about approaching plans, you don't have to wait for the plan to send you an agreement. You can put together a term sheet and negotiation with the plan on where you want to go. And you want to think about things like having the plan be transparent about their attribution methodology, having maybe even an attached Excel document that clarifies all the variables they're going to give you from the claims file, as well as eligibility, alignment around provider roster. So there are some things you can do. Just want to make sure, because I know it can be really frustrating, and none of these are magic bullets. With that, what I want to do is maybe start with Errol and say, Errol, if you had to choose either as a provider or a payer, maybe the top 3 or 4 most important data sources, because, I think we sometimes get overwhelmed, right? There's so much data. And we're all so excited about it. And at the end of the day, of course, to your point, Errol, sometimes we have to block and tackle and fax something, and we're going to do that if that's what we have to do. So maybe, each of you just talking about what are just the top 3 or 4 most important data sets you feel a provider needs to be successful in risk and that a plan needs with them, and some of what you've seen in the market around that. So again, I'll kick that to Errol.
Yeah, thank you. So I think number one, and you called it out, is the attribution methodology and what would be considered a patient that's attached to a provider and why, and when does it change, and really getting that in black and white to understand what you're going to be accountable for. Because you could end up doing so much work for a patient only to uncover that you're not getting credit for it. And that's the worst thing to happen. So really diving deep into the details in terms of, okay, if there's a quality incentive program, what's the deadlines? When does that member count as part of my panel versus when does it not? What happens in December? What if that member leaves last minute? Am I going to be held accountable to that, like in the last month? Those are the key questions to understand, just to know, to level set and know what your denominator is. You have to know what your denominator is before you sort of chase the numerator. I think the second one is very important, is claims data. If you start to take full risk or you're getting downside risk, you can get getting access to that data. And it's not just to get a dump of claims, but what you're really trying to understand is where the costs are and whether the opportunities. So just getting claims data is not enough. It's more so having a platform where once the data is there, you can clearly see, is my PCP trend going up? Is my professional spend going down? Is outpatient going up? By how much? What's the benchmark? Should I be going up that much? What's causing it? What's my pharmacy spend? What's the cohort of the membership that I'm taking care of? Do I have a disproportionate share of hepatitis B patients, or do I have a disproportionate share of HIV patients? Maybe that's what's driving some of these trends. And so it's really not getting data to boil the ocean, but getting data so that you can get to the insights on trends. And sometimes, like for example, PCP cost trends going up is a good news story, because that would lead to inpatient trends potentially going down if you're getting more access to care. And sometimes what we've seen, especially when you think about health equity and making sure that the most vulnerable populations get the care they need, sometimes PCP costs are too low. And so you're like, wow, look how low we've kept the PCP trends. It's like, well, actually, these are vulnerable populations that aren't getting to your office. So it's too low. This is scary, which means we have to think about maybe transportation or other vehicles to bump this up. This shouldn't be this low. And so if you just look at your own data without thinking about it holistically, that's why I went back to benchmarks for my comment, you sometimes are chasing the wrong things. And then sometimes you're trying to, penny wise, pound foolish. The one example I'll give is when Sovaldi first entered the market. Very expensive drug, 90-day treatment. I think it was $90,000 or $80,000, but it cured the patient. And very quickly, if someone had a disproportionate share of those members, they would say, I don't want that drug. The drug costs are too high. And in actuality, the strategy that we had with many of our patients and providers that had disproportionate share of those members was get them the access to the drug. Now, because they're on Medicaid, how long will I have to keep them enrolled to ensure that we pay back the $90,000 cost of the drug after a 90-day fill? So it was get them access to the drug. Now we have to make sure that they come back to the doctor's office in day 30, day 60, day 90, so that they keep taking the drug, so that they're fully cured of the drug. Now, because of the churn, right? How do we make sure that member stays active so that that provider gets the value of providing that treatment to that member? That's a very nuanced approach that if you didn't have the data, you may have said, okay, the argument would have been, I don't want these members on my panel, they're too expensive. And that's not where you want to start the conversation, versus these are members that need care, let's take care of them, and then let's think about the value equation.
I love what you just said, Errol. I can't tell you all how often in my career growing up, I would hear people talk about bad patients or, the hot potato. And it really, I think that Errol hit home, using claims data, whatever you can get from EMR, ADT data to the extent you can get it, right? Some of these basic data sources can really help you help these people who are people, not bad patients, right? They're human beings who you have to understand. So I really love that. Dr. Talamantes, I'm going to kick it to you to say it again. So if you had your wish, top priority, just the most important 3 or 4 sets of data, data types that you think you would need to really be successful or have today, for instance.
Yeah, as a community health center, in taking care of several types of many patients, but different payers, I think it's been great to both start really looking at not only clinically what's going on in terms of what the conditions are we're managing, but as shared by Errol, is that we also are starting to see on the hospital side what patients are being hospitalized at a network and why. And again, a lot of that has to do with we're in 2 very different counties, 2 very different approaches to our safety net patients. And so that's really been helpful because it's changed the way we think about, one, yes, we have a global strategy, but also looking at and ensuring that we respect that healthcare is local. And that oftentimes is what's driving, when we look at our hospital claims. And same thing, I think specialty, sometimes we want to see those costs go up, but invariably, we also want to make sure that we see the hospital costs come down, meaning that those patients are getting the right care. And, again, it's part of our transition to not only move in the primary care setting from fee-for-service, but also moving our specialists away from a fee-for-service arrangement. And that obviously is difficult in the sense that, a lot of times, the specialists are also still catching up in terms of they're asking us for data. And so it's really trying to work with them through, again, our managed service organization to include them. And so we've developed a very robust joint operation meetings where we come together, not only with our health plans, but some of our most important partners on the hospital side and specialty side. And so that's also not only looking at specialty claims data, but as a primary medical group and engaging our IPA physicians too, our primary care physicians, is activating our community health workers to be more involved in some of these cases, not just on the primary care side, but specialty and hospital side. And so really getting outside our 4 walls and both being able to, at the point of care, for example, as a physician, I don't just want to know a patient is experiencing homelessness. I'm more interested in understanding what's already being done about it. And so making sure that there's not only the quantitative, collection of data and identifying people for their social needs, but making sure that our community health workers understand not only how to collect the data, but how to act on that data and also be able to put into the chart, Dr. Talamantes, this patient has these social factors. This is how we've intervened. Here's what we need from you as a provider to emphasize, so that I can focus, or we can focus on the clinical side and do our own clinical interventions, but being assured that on the social side, we're addressing some of those factors, and it doesn't fall always on the shoulder of the doctor. Of course, a doctor can refer into these systems, whether it's intensive care management or getting the community health workers involved. But we're trying to be a lot more proactive so that a lot of that work's already being done before the patient even shows up to a primary care or specialist or even the hospital. So there's a care plan already in our system that we can activate. We don't have to start from scratch every single time. So I would say that, to me, I would say from a disparity standpoint, that's something that in terms of addressing those to advance health equity, is important is taking these signals, interpreting those signals, and then understanding that, yeah, clinically there might be something going on where we can intervene and making sure that's the right intervention, but also socially making sure that we can activate the right team to address those needs that are non-clinical. And putting that together, I think we have seen the data, for example, some of our end-stage renal disease patients, we're doing a lot better being more proactive because that group has a really high risk of cardiovascular mortality, in making sure they're being seen, not only, of course, in the hospital when they need it, but once they get out, coming back to primary care, cardiology, nephrology, and having, again, a lot of those social needs that are barriers, transportation or other, being addressed so that they're not just ending up in the ER or hospital for dialysis because they missed or didn't have the support. So those are some really neat outcomes that we've seen, both not only financially, but we're seeing on the health side that we're closing the quality gaps and also making sure those patients don't end up in the hospital unnecessarily.
Thank you so much, Dr. Talamantes. Jing, you've been also in analytics probably longer than any of us. So your thoughts on kind of the most important priority data sets and data roles?
Sure. As a provider group, if we when we negotiate a VBP contract with health plan, when I sit across the table from Arrow, so when it comes to data, 3 pieces of information I would pursue. One is eligibility. The second one is claims data. The third one is revenue information. Related to that is the risk scores adjusted for the revenue. So I'll elaborate a little bit about each piece. Eligibility, what's important, that's your base, that's your population. And you need that information, especially related to patient demographics and social, factors. That's how you start with. And the one thing you need to emphasize on that one is the attribution methodology, just like you mentioned, Alan, because a lot of patients, health plans have this auto assignment process, and sometimes those methodologies are really, not reasonable. You get hit with somebody you're never able to engage. You want to make sure you get the patient you can engage, you can manage. This is the eligibility side. On the claims side, of course, claims everything, you run everything, your data analytics based on claims. 2 challenges from our experience. One is many health plans are very reluctant to share the financial information, to share the payment information, especially from hospital systems, from other provider contracts, because their concern is they don't want to reveal their contract information. That's the biggest challenge we encountered, but it's very important for VBP contract to be able to manage cost. So from that, we work very hard, push very hard with the health plans. At the same time, we work with the state. The New York State, when they put out the VBP roadmap, we want to ensure from the policy level, they include this requirement so that the health plan can, incorporate, these financial data for us to manage. The other piece, I see a message in the chat box about mental health. That's another challenge in the state of New York. There is a privacy requirement, for the mental health related claims. And a lot of times we are not able to get those information. That's a missing piece. Of course, we have some other ways to try to deal with it. The last piece is the revenue. Revenue is very important. We focus on managing our cost and utilization, but at the same time, it's 2 sides of the equation. Your revenue increase, it will impact it directly to your bottom line. And revenue, big part of it is the risk adjustment factor. And in the Medicaid, in New York State, especially Medicaid world, they're using this CRG. CRG it's a very complicated, high level, unlike HCC on the Medicare side, where we can get patient level information. That's another challenge when we work with our health plans, because CRG usually the premium is based on the group, the premium group level. It's very hard to get those. So those are the 3 kind of the major pieces of the data we will pursue and the related challenges in each of those.
Thank you so much, Jing. I feel like this is healthcare data 101. I really, really appreciate that. Really fantastic. So we had a question about predictive analytics. So I'll give my take on that, and then I'm going to ask the smarter, wiser people who I invited to join me today to talk about it. What I will tell you guys is that generally predictive analytics, it's kind of like Errol's point about faxes. You didn't hear Errol saying we don't fax. He said it would be nice if we didn't have to, but he understands the need to block and tackle. Predictive analytics to me can be a similar bugaboo at times. So if you think about what everyone's been telling you about the types of data you need, right? You can run something with claims and other really just claims alone called a patient 360, for instance, and really understand in detail for each of your members, their chronicity, their utilization. If you have social determinant data, the way Dr. Talamantes does, you can add that as well and get a picture and then put them into the right care model, right? Plug them into care transitions or complex care management or disease management, depending on how your care model works. And so when we think about rising risk versus predictive analytics, what I've seen is that there's a lot of blocking and tackling you can do with data today, so long as you really dive in and understand that data, organize it at both a physician and member level and connect that to your care model and your care team, it can be very powerful. That said, I'm going to throw it over and maybe go backwards this time, Jing, kind of throw it to you first as our deepest data person. What are your thoughts on predictive analytics, where it is today and where it might be going, and what you see personally in your work as either a value or not so much yet?
Well, this has always been the crown jewel in the data analytics, try to predict the risk of your population, identify the potential emergent ER visits or inpatient admits. And traditionally, when I was at the health plan side, we use some standard tools like DXCG by Truven or ETG, whatever. They have a predicted model to predict probability of an ER visit within the next 6 months or 12 months, whatever it is. And of course, there are a lot of other smaller companies and developing these predictive models specifically fine-tuned to those population. I also worked with some vendor companies, giving them our population data for them to develop our population specific models. So this is very important. You can only do so much in your general population profiling, identify chronic conditions. Really, you need to take more targeted action for those emerging risks. That's where the predictive modeling, come into the play. And I think right now this is still an area and open for a lot of development. If I have to predict, the future in the data analytics field, this is one of the areas where we'll see a lot of, development, especially with the recent development in AI and all these fancy algorithms.
Thanks, Jing. That's really helpful, and a lot of where I've seen it is we want it, we need it, maybe not quite here yet. Dr.
Exactly.
Talamantes, your thoughts on this?
Yeah, I would say at least for us, it's still pretty early. I mean, that's something again that it's a pie in the sky that we're striving for. But we're also very cautious in the sense that we want to make sure that the prediction isn't going to adversely impact our patient population. So just being mindful that within the structures of how we collect data, what kind of data. We have an Institute for Health Equity at Ultimate, and we've been really pushing our team to try to move away from just collecting sort of deficit social data to really understanding even those communities that are facing some really difficult circumstances, trying to capture data that's more strength-based. To be able to really work with community. We have, for example, our clinics are based out in our housing developments here in East Los Angeles. And so really thinking both not only what tools we use to stratify, but challenging those tools by understanding the narrative in the community, which is more qualitative. And so that's what I would say is one thing I would try to push for is not just binary data or traditional data we're collecting, but thinking about some of the qualitative data that comes with that, and using tools that can help us interpret some of that data and then screen. I think even if we have data, I think it's always verify, verify, verify. To make sure that we're doing the work that we're being asked to by the patient, not necessarily by the utilization trend that we're seeing.
Thank you so much. And Errol, kicking it to you.
Sure, I will be the wet blanket, unfortunately, but things to think about for predictive analytics. And this is things that we've learned by making mistakes. You have to have a really robust, I believe, bias council or committee just to ensure that the data you're collecting is going to have bias in it automatically, because our healthcare world has bias. And so the data we're collecting to make predictions is going to be embedded with bias. And you just have to have the right people to think through those impacts so that you're making the right decision. The one that comes to mind that's so just obvious was an algorithm that showed people who had high costs versus lower costs. And they said, we're not going to have any bias, so we're going to take out race. So they input race in the algorithm. And what ended up happening is they were doing care management programs for predominantly white patients, because what was happening is the African-American patients had low cost, not because they were healthy, but because they had lack of access. And so that predictive modeling could have totally run amok in approaching the wrong patients. And New York State actually had sanctions on that algorithm for a plan that will remain nameless. And they had to totally revamp their algorithm. So whenever I hear predictive modeling, I think technology is great. We just have to have the right guardrails to make sure that we use it appropriately.
Errol, that was
And the
brilliant.
other-
I mean, not
the other
that
quick
everybody
point-
wasn't brilliant. Oh, go ahead, Jing. Sorry, let me let you.
Sorry,
jump
I
in.
just want to make sure, just a quick point. And the traditional predictive modeling mostly rely on claims data and information on the health plan side. Now with interoperability, and we get additional data from the EMR system, from social determinants of health, that will help,
Yes.
empower the modeling. Yeah.
Yes.
Absolutely. I mean, thank goodness the technology is getting better. So for instance, we're doing what's called an API. I think someone mentioned that earlier, a direct two-way connection with an EMR starting in Hawaii and some other folks nationally. It's challenging, right? There's lots of EMRs and IPAs. There's no magic sauce. You can, of course, though, as Jing and others would tell you, you can just get a download from the EMR once a month, and even that will deeply enrich your claims data. So I know we're coming up on time. And so what I would say is, first of all, I would thank all of you for joining, for the great questions. Deeply, deeply thank Adamika for setting this up, and Jing and Dr. Talamantes and Errol for your incredibly valuable time that you've decided to spend with us today. And I think as final words to folks, it is taped, and Adamika and our team are going to work together to get a really nice summary, because I noticed some folks came late and missed the amazing Analytics 101 that Jing and Dr. Talamantes and Errol went through at the beginning. So we'll make sure we capture that. The key things to keep in mind from my perspective now as I get older is, that old rule KISS, keep it simple. Keep it simple is so important. So remember, make sure you're clear with the plan about what data you need. We talked about attribution. We talked about the claims, the eligibility, alignment on provider roster. If you have access to EMR data, you don't have to do an API. You don't have to get integration. Get an SFTP dump, focus on the basics and get that integrated so your quality and your HCC care gap chase lists are at least up to date. So there are some really simple, awesome things you can do. And then, of course, there are more complex things you can do, such as what Dr. Talamantes alluded to with the great work Ultimate's done. So at 12:59, just going to say thank you very, very much and hand it briefly to Adamika.
Yeah, and I just want to say thank you as well. I was going to say a joke in the beginning, which is that we often don't do manels at Health Tech for Medicaid, but when we do them, they are very diverse. So I wanted to at least make sure that was acknowledged as well. Always a repository and a think tank. We have a event once a month called Health Tech for Medicaid 101, where you can spitball and ask questions. It's kind of our ear to the ground, but always a pleasure to be in community with thought leaders. Specifically here on the payer and provider spaces, we're looking at data analytics and how this is truly impacting all populations, but specifically will really help us provide care for vulnerable populations in this country. Deep appreciation to Alan, a longtime colleague and friend, and to all of the rest of you. Looking forward to our next time coming together. Thank you so
Take
much.
care, everyone. Safe travels. Have a
Thank
great day.
you.